Hi, I'm Dr. Jochelson. I'm a diagnostic radiologist, and I'm the director of imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center. So the whole issue of screening for breast cancer has been and remains a major area of controversy, despite the fact that we have demonstrated that by screening, we reduce breast cancer mortality. There are currently at least 3 different sets of screening guidelines. The first set that I'm showing you here is the one that I use and my colleagues use, and also the Society of Breast Imaging and the American College of Radiology. And this is for women at average risk for breast cancer. They should start their annual mammography beginning at age 40 and continue until their life expectancy is less than 5 years. They should also have yearly clinical breast exams. The American Cancer Society guidelines recommend annual mammography starting at 45 to the age of 54, which could also begin at 40. And they recommended transitioning to every 2 years after the age of 55 until life expectancy was less than 10 years. But they also said that you could do it annually. And they did not recommend a routine breast exam by a physician and no self-breast exam. The United States Task Force, and this was probably the biggest scandal in 2009, came out with guidelines, and these were also to actually advise the government about what they would cover. And they recommended that women between the ages of 40 to 49 should discuss with their physician whether they should have any screening. They recommended screening every other year between the age of 50 to 74 and no self-exam. So this is a dramatic change from the one that I showed you that we all recommend. A model of the mortality reductions comparing the standard guidelines, which I showed you, to the task force guidelines is shown here. And what they did was they looked at the reduction of mortality at 6 major institutions and compared the reduction if you did the task force guidelines or the standard. And what they demonstrated is by doing the standard, you did 25,000 more mammograms in 1,000 women. However, there was an additional mortality reduction of 16% compared to doing the task force alone. So you can see in the top line, the mortality reductions were in the 20%. And the standard reduction is between 30 and 50%. So by doing these yearly mammograms starting at 40, you are reducing mortality in a significant number of additional patients. Screening mammography, however, is limited. We miss cancers, especially in women who have dense breasts. We call back patients for additional imaging. And the concern of the task force is that the anxiety that we provoke by calling patients back was a major limitation to doing mammography. And the term overdiagnosis, i.e. finding cancers that will not kill the patients. However, I don't believe that it's overdiagnosis. It's accurate diagnosis with maybe overtreatment. So we do know that we need to do better than just mammography alone in this setting. So we have multiple new studies that we can use. Screening ultrasound has been evaluated by many investigators in the setting of patients with dense breast tissue. The landmark study was the Akron 6666 trial, in which nearly 3,000 women with dense breasts and another risk factor underwent physician-performed screening ultrasound, and they did in fact find approximately an additional 3.5 per 1,000 cancers. These cancers were invasive, small, and they were primarily node negative. Unfortunately, screening ultrasound has a large number of false positives, and this too, therefore, adds to the anxiety of the patient. We have also recently demonstrated that women who don't have breasts don't need to undergo screening ultrasound. The high false positive rate certainly is a major limitation without a benefit to finding additional cancers in that population. Christiana Kuhl took a look at women with increased risk, and she looked at the cancer detection rates of all the different modalities. And as you can see here, mammography may find 5 cancers per 1,000, ultrasound 6, if you combine them 8, but MRI will find twice as many breast cancers. So this really needs to be considered in women at increased risk. And this is something that is standard in women who have a greater than 20% risk for breast cancer, as you can see here in this study published in 2007. And this includes mutation carriers, untested first-degree relatives of mutation carriers, women who have a lifetime risk based on family history of greater than 20%, and women who have received radiation therapy to the chest when they were young. Women at high risk should also start mammography earlier than 40. And most people suggest that you should start 10 years earlier than the youngest person who had breast cancer in the family, although probably you don't really need to start women at under 30, and maybe not even under 40 if you're doing MRI. Ultrasound does not add anything to screening if you are doing an MRI. And multiple studies looking at screening MRI in high-risk women demonstrate a significant increase in the sensitivity of detection with MRI compared to mammography. And you can see that the sensitivity is up to 100% in many of these studies. People are concerned, however, that mutation carriers may have more aggressive disease, and so computer modeling has been performed, and that has demonstrated that the most clinically and cost-effective way to screen very high-risk patients is to alternate mammography with MRI at 6-month intervals, starting at the age of 30. And this is just an example of why we do this. This is a patient who came in for a screening MRI. This was actually called BI-RADS2, benign. And then she came back 6 months later, and you can see that she has a cancer that has grown quite rapidly. Many people were not sure whether one needs to continue screening for high-risk women over the age of 50. Fee et al. Did a pooled analysis of 6 studies, and they demonstrated that the improvement in screening sensitivity using MRI is no different in women over 50 than women under 50. And therefore, they should consider doing MRI until the women get older. And in fact, this study by Kuchenbacher et al. From JAMA 2017 demonstrates that the increased risk of developing cancers in mutation carriers goes on until women are close to 80 years old. So in this population, we know that you need to continue doing mammography and MRI every 6 months until life expectancy for other reasons is less than 5 years. So in conclusion, screening mammography should be performed yearly, beginning at age 40 and extending to a woman's life expectancy being under 5 years. We have multiple technologies that can improve upon regular mammography, and this includes tomosynthesis, ultrasound, and MRI. In women at increased risk, if the increased risk is less than 20%, mammography plus ultrasound, or now you might even consider doing MRI or contrast mammography yearly in those patients as well. And women who have a greater than 20% risk should be screened with mammography or tomosynthesis plus MRI alternating every 6 months.